Good afternoon, everyone. I call this meeting to order. Welcome to meeting number 8 of the House of Commons Standing Committee on Health. Today we will meet for 2 hours, so because of the late start, that will take us to 6:14 Eastern to hear from witnesses on our study of Canada's health workforce. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. We are meeting in a hybrid format pursuant to the House Order of November 25th, 2021. Members attending in person in the room and remotely using the Zoom application. I would like to remind those that are participating virtually not to take screenshots of your screen. The proceedings will be made available via the House of Commons website. All public health advisories, including those of the Board of Internal Economy of October 19th, 2021, are in force and will be observed. To begin, each organization has 5 minutes to make their opening statement before rounds of questions for the remainder of the 2 hours. We are very pleased to have with us this afternoon the following witnesses. As an individual, Bacchus Barua, the Director of Health Policy Studies at the Fraser Institute. From the Canadian Association of Radiologists, Dr. Gilles Soulet, President. From the Canadian Federation of Nurses Unions, Linda Silas, President. From the Canadian Medical Association, Dr. Catherine Smart, President. And from Healthcare Can, Paul-Émile Cloutier, President and CEO, and Elaine Watson, Chief Human Resources Officer of Covenant Health. Thank you all for taking the time to be with us and to testify today. We will proceed in the order listed on the notice of meeting. So, Mr. Barua, and I hope I have pronounced your name correctly, you have the floor for 5 minutes, so welcome to the committee.
Thank you very much. Good afternoon, bonjour, and thank you for the invitation to contribute to the committee study on Canada's healthcare workforce. It is an honor to be here, and I hope what I have to say is of some value to the esteemed members. I should state upfront that although I'm the Director for Health Policy Studies at the Fraser Institute, a nonpartisan Canadian think tank, the organization does not hold any positions. Therefore, my testimony is based on my own views and published research. My understanding is that my job today is to try and set the stage by providing information that may be pertinent to the committee's subsequent discussion on the matter. As such, I'd like to focus on 3 areas. 1, highlighting Canada's relative scarcity of key medical resources. 2, decoupling the impact of COVID from structural issues. And 3, looking through the lens of supply and demand to identify potential solutions. First, let's take stock. Canada has a relative scarcity of key medical resources. That includes human and capital resources. Our most recent report on healthcare performance found that in 2019, out of 28 high-income countries with universal healthcare coverage, Canada ranked 26th for physicians, 18th for nurses, 25th out of 26 for curative care or hospital beds. Canada also ranked 22nd out of 24 for MRI units, 24th out of 26 for CT scanners per million population. This relative scarcity existed despite the fact that Canada ranked 6th highest for healthcare expenditure as a percentage of GDP and 10th highest for healthcare expenditure per capita in the same year. Second, it's important to acknowledge the pressures of COVID in the current context, but to not conflate them with larger structural issues. I provide 3 quick examples. A, the data I mentioned are from 2019. That's a year before the pandemic. B, Canada's relative scarcity of physicians spans decades. Physician density began to diverge actually in the mid-70s and deepened following the Veris audit report of 1991. While there has been an uptick since the turn of the millennium, projections from a 2018 report I co-authored suggest Canada will still have fewer physicians per 1,000 population in 2030 than the OECD average way back in 2018. It's worth noting here that Canada's relative scarcity is more prominent for specialists than it is for family doctors. Case C, wait times. Wait times have certainly gone up during COVID, but again, have been increasing for decades. The Fraser Institute survey reports an estimated 25.6-week wait between referral from a family doctor to getting medically necessary elective treatment in 2021. However, in 2019, again a year before the pandemic, the wait time was still 20.9 weeks. Similar observations can be made with other international surveys, such as those by the Commonwealth Fund, using the international surveys for 2020 and 2016. The takeaway is that context is important. COVID has exacerbated but is not the cause of the current challenges with the healthcare workforce. Moreover, the combination of backlogs due to surgical ramp downs, potential long-term effects of COVID, and an aging population will ensure that these challenges persist long after the pandemic is past. The obvious question is what can be done? Well, we need to start by understanding that the imbalance between demand and supply for medical services manifests in a number of ways that includes things like overflowing hospitals, which we had before the pandemic as well, overburdened staff, which we're currently grappling with, and ration care for patients, which Canada has struggled with for decades. Any solution, therefore, lies in reconciling the imbalance, this imbalance between supply and demand through either increasing supply, tempering demand, or better aligning incentives. Many successful universal healthcare countries, that includes Switzerland, the Netherlands, Germany, and Australia, just to take a few examples, do this in three ways. They embrace the private sector as a partner or a pressure valve on the supply side. They employ patient cost sharing on the demand side to temper demand, with, of course, supports for vulnerable populations and exemptions. And three, they encourage competition and incentivize treatment through activity-based hospital funding, which contrasts with Canada's global budgeting approach. Now, in the absence of these types of reforms, solution improving efficiencies at the margin. However, these will cost the government money and be limited in scope. For example, supply can be expanded in a number of ways, including increasing domestic enrollment and residencies, which are also very important for physicians, as an example, promoting immigration of foreign trade physicians or other important healthcare staff, such as nurses, and increasing the adoption of new technologies, such as telemedicine, otherwise known as virtual care. Each of these face very unique challenges, but they're not insurmountable. For example, it takes a while to train doctors domestically. Virtual care may eventually face challenges from the CHA, the Canada Health Act, and there's no point having more doctors if their services are not funded or if they can't find employment, both of which are documented problems under Canada's global budgeting approach for hospital remuneration. In summary, there is a documented relative scarcity of key medical resources. This scarcity is structural and will persist in the post-pandemic world. Solutions do exist within the current framework, but in the absence of potentially significant reform, they will likely be expensive, limited in scope, and only temporarily successful in nature. I hope these have been of some value to the members of the committee.
Thank you very much, Mr. Barua. Next, we're going to hear from the Canadian Association of Radiologists. Dr. Soule, you have the floor for 5 minutes.
Thank you, Monsieur le Président, membres du comité.
Thank you, Mr. Chairperson, members of the committee, fellow panellists. My name is Dr. Gilles Soulez, and I'm the president of the Canadian Association of Radiologists. I am the former chair of radiology at the University of Montreal and an interventional radiologist practicing in Montreal. It's an honour to be here with you today, unfortunately under dire circumstances for Canadians who need health care. Our workforce is burned out and we need short, medium and long-term investment today. There is a shortage of healthcare workers also. Medical imaging, as you're aware, is the gateway to our healthcare system for the diagnosis of disease, but it is also necessary to guide and evaluate the effectiveness of treatments. Interventional radiology also allows for minimally invasive surgeries to be performed on an outpatient basis with minimal cost and morbidity. Whether you have a stroke, cancer, trauma, or a herniated disc, imaging will often be required at several points in your care. In the time I have allotted to me, I'll speak to three issues. 1. Excessive and growing wait times. 2. The need for health human resources investment. 3. The need for capital equipment and information technology to allow for these human resources to be optimized. First, wait times. Canadians are waiting too long for diagnostic imaging procedures, and the pandemic has made this situation only worse. I am originally from France. When I arrived in Canada, in 1991, Canada was one of the first jurisdictions that had reasonable wait times for medical imaging, quote unquote. After nearly 20 years of underinvestment in the healthcare infrastructure, wait times are again exceeding the P3, Priority 3, 30-day wait time across the Canada. Prior to the pandemic, patients were waiting on average 50 days for CTs and 69 to 89 days for MRI diagnostics, which is already far too long, and these numbers have continued to grow due to the pandemic halt in testing. This resulted in a 50 to 70% decrease in radiology services across the country at the worst point in the crisis, and this has not returned to normal. Our healthcare system is not currently equipped to handle these volumes. If this situation persists, we are at risk of leaving many patients undiagnosed and untreated. In 2019, the Conference Board of Canada estimated that the cost of these excessive wait times resulted in a loss of $3.7 billion in GDP and $400 million in lost tax revenues in 2017. These costs are certainly going to be worse in 2022. Second, human resources in the healthcare area, the pressures and a plan. Excessive wait times led to a situation where medical radiation technologists, or MRTs, sonographers, are working overtime to try and keep up with the demand. Many of these frontline workers are burned out, getting sick, including getting COVID, and exacerbating an already dire situation for patients. But the human cost of nearly 24 months of overtime has had a generational impact on these frontline healthcare workers. It is our responsibility to put forward a plan to make their lives better and take better care of Canadians. 2, investing in health human resources now. Canada has the lowest ratio of MDs per population in the OECD. We need more training programs. A recent survey of our members indicated that 70% of radiologists see the shortage of staff as the most significant barrier aside from the lack of modern medical imaging equipment to addressing wait times. Currently in the Gatineau region, 25% of the technologist positions are not filled. It's difficult to recruit technologists in the downtown areas of large cities because of the cost of housing and transportation difficulties. These technologies are usually helpful with less repetitive human intervention. They also ensure that the exams are relevant and reduces unuseful and unhelpful exams. An investment in medical imaging equipment would be necessary. In 2019, the Conference Board of Canada estimated that approximately 30% of our diagnostic medical imaging equipment is 10 years or older. We would not drive cars that are old. Do we really want to be using these machines to diagnose and treat patients? Furthermore, investment in diagnostic imaging equipment across the country is at a 20-year low. Having newer imaging equipment, specifically MRI and CT, can efficiently move patients through the system. New equipment has the capability to do scans more quickly. The new technology allows for reduced wait times in procedures. In 2003, the federal government, under Paul Martin's leadership, injected $1.5 billion in medical imaging equipment. This really helped Canada to ensure equitable access to medical imaging for all Canadians. The time has come once again to invest in medical imaging equipment and to develop a health human resource strategy for radiology to avoid crippling our healthcare system and to ensure patients are receiving the right test at the right time, ultimately saving lives. Currently, in summary, excessive and growing wait times in medical imagery meaning our healthcare system is no longer effective and efficient because it has a bearing on the entire process that patients undergo. We need health and human resource investment. We need capital equipment and information technology to allow these human resources to be optimized. An investment of $6 billion was included in the 2021 Liberal election platform to reduce wait times, and MRI was specifically referenced. That's where we have the biggest delays. Investing $1.5 billion in equipment will not only benefit our frontline responders. Sorry, sir, Dr. Soule. Dr. Soule, unfortunately, your time has run out. That's okay. I had finished. Well, please finish your remarks now. Well, this investment will ensure our long-term recovery for the pandemic, while at the same time ensuring that patients are receiving their lifetime care that they need. Please don't hesitate to ask your questions. Thank you, sir. When we get to the question and answer period, you'll have an opportunity to speak at length, I'm sure. There'll be questions for you.
Nurses Unions, Linda Silas, you have the floor for 5 minutes. Welcome.
Good afternoon, everyone. I'm calling from the Ottawa, the beautiful land of the Algonquin and Anishinaabe people. Mr. Chair, committee member, thank you for inviting me to present to this committee on behalf of the Canadian Federation of Nurses Union. As stated, my name is Linda Silas. I'm national president. I want to congratulate the Health Committee for undertaking this important study. In my world, we would call it retention and recruitment, because if you can't retain your nurses, you will never be able to recruit any. Prior to the pandemic, nurses were exhausted, burnt out. A University of Regina report on nurses' mental health, which surveyed over 7,000 nurses, found that nurses screened positive for symptoms of PTSD, anxiety, major depression, similar or higher rate than public safety officers. 29% had symptoms of severe burnout in 2019. Today, it's 45%. The health workforce accounts for more than 10% of all employed Canadians, over 2/3 of all healthcare spending, and nearly 8% of Canada's total GDP. Nurses are the largest group of regulated professionals in Canada. We have over 450,000 nurses who are responsible for the much direct care, hands-on care provided in Canada's health system. And CFNU proudly represents most of these workers who are there 24/7 at their patient's side, either in ICU or in long-term care. The Conference Board of Canada recently reported that by 2026, Canada could lose 20% of its healthcare workers due to retirement. Let's remember that over 50% of our health workforce are nurses. In fact, Stat Canada reports that over a 2-year period, the number of vacancy for nurses more than doubled. CFNU surveyed nurses across Canada just prior to the Omicron wave. 80% of nurses said there were not enough staff scheduled to meet the demands of patients or residents in long-term care. Nurses also routinely report 16 to 24-hour shifts in some jurisdictions. This isn't safe. What does it mean to start your shift at 7 a.m. and think you're done by 3 or 7 p.m. just to be told you are mandated to stay because they are short? Nurses like Pauline, who's a single mom with 2 kids, who does she call at 7 p.m. to come and take care of her kids? Or Yvette, who needs to wear full PPEs that looks like hazmat suits for her whole shift, but Yvette can't even get a glass of water because all the break rooms are too small or just plainly closed. Then she's asked, please just stay a little bit longer. 1 in 2 nurses say they are considering leaving their current job in the next year. And I'm pretty sure you're not wondering why. The reality is we can expect even more nurses will head to the doors unless immediate actions are taken. Before I finish today, I'll share with you 2 more comments from nurses who are working today while I'm in Zoom speaking to you on their behalf. Nursing is my life. I've loved it and loved being a nurse for over 20 years. I hate the feeling like it's the worst job ever now and that no one even cares of what's going through. Another one shared with me, I am just making an exit strategy. Please hear their voice now and commit to immediate funding for innovation project to retain both our experienced nurses and the new nurse graduate who will not survive in their job unless things are radically changed. And please, let's not play the political football of whose responsibility it is. You represent Canadians in every part of this country. That includes Canada's nurses and Canada's patients. Now it's time for us to discuss solutions such as funding for students, bridging program, initiative for late career nurse and new grads, safe nurse-patient ratio, safe working condition, free from violence and mandatory overtime, permanent full-time job with respectful salaries and benefits, and a national body or agency to provide the best data and strategies to the province and territories. This is a critical moment for nurses and the people who we care for. Today's crisis was years in the making. And if we don't act now, we risk suffering a system-wide failure of our treasured universal public healthcare system. Once again, merci, thank you to the members of the committee, and I'll answer your questions later.
Thank you, Ms. Silas. Next, Dr. Catherine Smart, President of the Canadian Medical Association. The next 5 minutes are all yours.
Thank you, Chair and committee members, for the opportunity to appear before you today. I'm Dr. Catherine Smart, and I'm speaking to you from the traditional territory of the Kwanlin Dun First Nation and the Tongkwatchin Council. I'm a pediatrician based in the Yukon. As president of the Canadian Medical Association, it's an honor to represent physicians and medical learners from all jurisdictions. Every one of us has felt the impacts of a healthcare system stretched beyond its capacity. For health workers, the pandemic has been unrelenting. We're burnt out, exhausted, and demoralized. In caring for patients in an already broken system, we've been pushed to breaking and beyond. Each wave submerges us under deeper layers of backlogs and with even greater workforce and systems impacts. Our health workforce is in the biggest crisis we've ever seen. Last fall, the CMA and the Canadian Nurses Association co-hosted an emergency summit to learn from nearly 40 health organizations representing nurses, physicians, respiratory therapists, personal support workers, psychologists, and educational institutions. They all agree. It's an unprecedented crisis. There's no question the CMA is grateful for the federal government's integral part in the pandemic response, but it's not over. And even when it is, healthcare will feel the repercussions for many years. Healthcare workers are relying on the leadership of the federal government to support a way forward. By aiding medical professionals, you are helping every Canadian, now and in the future. Chair, having this committee study Canada's health workforce is welcome. There is more to learn of the crisis, but let me tell you what's happening now. Physician burnout is at an all-time high. More than half of physicians report high levels of burnout, nearly double pre-pandemic levels. And nearly half told us they are likely or very likely to reduce clinical hours in the next 24 months. The repercussions of this could be devastating. Already, more than 5 million Canadians don't have a regular healthcare provider. Only 40% of them can get an appointment within 48 hours. Rural and remote communities and marginalized and at-risk populations are even more disadvantaged. Over time, we've also created barriers for doctors and nurses practicing in a new province or territory. It is why the current regulatory licensing frameworks need to move to a pan-Canadian licensure model. This would allow health professionals to work where they would like and where the needs are the greatest. It's time to remove these unnecessary regulatory obstacles. Prior to this pandemic, our healthcare system was ailing. Today, it finds itself with more cracks than ever. Worse, those who work and care for Canadians are exhausted, burnt out, and leaving. The result will affect every single Canadian and put their health and ability to access their health system at risk. This crisis has ballooned past what any jurisdiction can manage alone. We know that the premiers are focused on an increase in unconditional federal dollars. We believe that more strategic federal investments are required now to support rebuilding healthcare delivery in Canada. First, we need federal leadership for pan-Canadian integrated health human resources planning. An intergovernmental approach led by the federal government is now required. Second, it's time to deliver on the promise to increase patient access to family doctors and primary care teams by delivering on the $3.2 billion commitment. As part of this commitment, the CMA recommends that $1.2 billion over 4 years be dedicated to a primary care access fund and $2 million to undertake an assessment of interprofessional training capacity of family physicians and other professionals in the area of primary health care. Scaling up collaborative interprofessional primary care is central to increasing access to care. Third, we need to eliminate barriers for medical professionals by enabling the adoption of pan-Canadian licensure. Medical professionals need to be able to move from province to province to deliver care where it's needed. The past decades have witnessed remarkable advances in medical science, but we are still reliant on health workers. So just as they have stood at the front lines, it's critical that the federal government create pathways that will stand for the protection of health and medical professionals. We need the federal government to finish this long shift with us. Thank you, Chair.
Thank you very much, Dr. Smart. And last but not least, Healthcare Canada, Healthcare Can, Paul-Émile Cloutier, will you be speaking for the delegation? You're on mute, sir.
Yes, I will be.
Very good. The floor is yours for 5 minutes. Welcome.
Mr. Chair, members of the committee, my fellow presenters, thank you very much for the opportunity to speak to you today. And I am joined by my colleague, Elaine Watson, who is the Chief Human Resources Officer at Covenant Health in Alberta, one of Canada's largest Catholic healthcare providers. Ms. Watson is also the co-chair of the Healthcare Can Health Human Resources Advisory Committee and will be available to answer many of the questions that you will have. En tant qu'organisation nationale,
as the national organization representing hospitals, health research institutes, and healthcare organizations, what I repeatedly hear from health leaders is that human resources is the #1 challenge facing healthcare organizations right across Canada today. It needs to be addressed as quickly as possible.
Because healthcare and its people is a people business, and healthcare workers are the foundation of our health system. I commend the committee for taking the time and to study this important issue, which has been neglected for far too long. Health workers are more than nurses, physicians, and personnel support workers. They also include support, custodial, and administrative staff. They also include researchers, the lab techs, and leadership teams. And all of these people are needed for the health system to function and deliver quality care to Canadians. So when we look to develop health workforce solutions, we must consider all these people rather than take a silo approach by profession. It has to be a multi-professional approach. The exhaustion and burnout felt by too many healthcare workers due to the pandemic has made a previously tenuous situation far more critical today. There are job vacancies throughout the entire system and likely more to come once the pandemic subsides. Many healthcare workers are choosing to retire earlier, move to less demanding roles in the health system, or leave the system entirely. While the waves of the pandemic increased demand on the system, healthcare needs remain even once the worst of COVID-19 recedes. There is still heightened demand on the system as healthcare workers deal with medical procedures backlogs, caring for people who have delayed treatment and who come in sicker. The treating of the population that is living much longer and often with more complex and chronic conditions. Mr. Chair, we must rethink our entire health system and address health human resources challenges must be central to this to ensure a more resilient system that can respond to people care's need. Nous avons besoin des solutions innovantes à court.
We need innovative short-term and long-term solutions to address health workforce concerns. Having the right mix and number of healthcare workers is in the right place at the right time to meet the needs of people across Canada is paramount. Healthcare Canada is recommending that the federal government work on the following.
Is to improve the immigration process to better leverage the skills in newcomers to help meet existing health system needs over the short and medium term. The second is to collaborate with other levels of government, regulators, and educational institutions to increase the number of Canadian-trained healthcare professionals in the right roles to meet long-term needs. The third one is to collaborate with provincial and territorial governments and healthcare organizations across the country to support the health, wellness, safety, and resiliency of the healthcare workforce. This could include increased federal investment in mental health and wellness research, program, and resource specific to healthcare workers. The last one is to establish a pan-Canadian health workforce agency responsible for strategic and standardized health workforce data gathering, research, and planning to help us better understand the current workforce and its future needs. This agency could work with provincial and territorial governments, regulators, and healthcare stakeholders using the information it collects to develop and implement strategies to address systemic health workforce concerns. Les Canadiens attendent que le...
Canadians are waiting for the federal government to play a leadership role and to address these issues in collaboration with the provinces, territories, and all healthcare stakeholders.
Clearly no longer an option. Failing to act now will lead to lower quality care, longer wait times, and worse health outcomes. Thank you.
Thank you, Mr. Cloutier. Before we begin with the rounds of questions, I just want to make sure that I haven't improperly spoken for the committee. I indicated at the outset that we would be sitting until 7:14. What I should have said is that we have the support of the fine folks of the House of Commons for the full 2 hours if it is the will of the committee to sit the full 2 hours. So, sorry. Oh, there we go again. I'm back on Atlantic time and I'm in Ottawa. Yeah, okay. So we don't have the support. Do we have the support of the committee to sit until 6:15? We're okay? Okay on the screen? We have consensus in the room? 2 full hours? Excellent. We will now begin with rounds of questions, starting with the Conservatives. Dr. Ellis for 6 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for appearing here. It's a daunting task and certainly one that I have experienced firsthand as a family doctor who provided all aspects of care. So thank you for coming and attempting at some point to ameliorate this situation. I guess for our first witness, my question would be, thinking about the current funding model and the 7,500 healthcare workers promised by the Prime Minister during the election and also repeatedly during question period, can you, sir, tell me how many of those healthcare workers have been provided to our current system? I did. Sorry, Mr. The first speaker, Mr.
Barua.
Barua.
The question's for you, Mr. Barua.
Well, thank you for the question. I don't think I commented on that, and I won't be able to answer that question.
Well, thank you very much. And perhaps, Dr. Smart, maybe from the CMA, I would ask you that same question, ma'am, if you don't mind answering.
Thank you for the question. I think at this point we don't have the data to know how many additional primary care providers have been given into the system. I think what we certainly know is that there are major barriers right now for people providing longitudinal family practice type care, as well as many barriers to providing integrated team-based care. This partly is what underlies our desire to see integrated health workforce planning, as we feel we need to understand the direction that we're headed in terms of providing integrated team-based care, why some people are choosing not to provide that type of care, and the number and the types of providers that are needed to make sure that every Canadian has access to primary care. And that work has not yet been done, and we feel that that is critical as we move forward.
Okay, thank you. Perhaps from the CNA, Ms. Silas, do you know, have any nurses been recruited from the 7,500 promised by the federal government?
Good afternoon, Dr. Ellis, and hello from another Maritimer. No, we don't. Dr. Smart was very clear on that's one of our asks, is that the federal government takes the lead of getting the proper data. Where we know there's been an increase is in the personal care worker workforce. You've seen that both in Quebec, Ontario, a little bit in Alberta, and that's about it where we have concrete actions for increasing staff. You read the last Stat Canada report, over 118 vacant positions in the healthcare workforce, in the regulated healthcare workforce, and that's not included personal care workers.
Thank you. Mr. Barua, if I go back to you, sir, do you know any idea of the number of healthcare workers that Canada may need to help fill any of these vacancies?
I'll narrow the question down to physicians, because that's really what we've looked at quite a bit. What I can say is that in 2019, Canada had, as I mentioned, Canada ranked 26 out of 28 for the number of physicians per 1,000 population. I don't have the data right in front of me, but I believe that was equated to about 2.8 physicians per 1,000 population compared to the OECD average of about 3.8. I may get my decimals a little bit mixed up. The calculations would be based on that. But of course, it's really, really important to narrow down exactly what the questions are, because, for example, as I mentioned, Canada actually does about the same or relatively a little bit better when it comes to family doctors per 1,000 population, and does significantly worse when it comes to specialists. Even though that's the case, the demand for a family doctor seems to be a significant issue right now. In my opinion, that really represents sort of a bottleneck where people are trying to get into hospital, trying to get treatment, but have to be treated by family doctors in the meantime. So with those ratios, like I said, I don't know what they translate into numbers, but that gives you a rough idea of how far away we are just from the OECD average. That's not counting the top of.
Great, thank you. By my math, that means we're short about 38,000 doctors compared to the OECD average, which 7,500 would be a drop in the bucket. It's interesting. I wonder if Ms. Silas, do you have any idea of how many nurses we're short? I understand we have 450,000 nurses in Canada. We're talking about losing perhaps 26% of the 50% of healthcare workers that nurses make up. Any idea of the number, ma'am?
Well, in your beautiful province, Doctor, it's 1,300. That is very clear number. It's easy to go from facility to facility to count the vacant position. In the province of Ontario, it's over 20,000 vacant position. So again, a very large numbers. And we're not even trying to reach the OECD average. We're trying to retain the workforce we have and to do like Nova Scotia did. Honestly, your premier promised jobs for the next 5 years for every nursing graduate in their region, and that's permanent jobs. So it's actions like that we need from all levels of government.
Okay, thank you.
And if we might continue.
Thank you, Dr. Ellis.
Thank you, Chair.
Yeah. Next, we're going to go to the Yukon. Dr. Hanley, please, for 6 minutes.
Thank you very much, and I want to add my thanks to all of the witnesses. Clearly describing the state of healthcare and human resources in 5 minutes is challenging for each of you, but really appreciate the different angles. And I do want to note that it's only about every 100 years that a physician is an member of parliament for Yukon, and it's only about every 23 years that a Yukoner is president of the CMA. So to honor that occasion, I'm going to direct my first question to my colleague and friend, Dr. Smart. And I want to maybe hear a bit more about how, in your view, burnout has affected not just numbers, but productivity of the physician community in general. And I beg you to keep it reasonably short and concise so I can get all my other questions in.
Thank you, Chair, and thank you, Dr. Hanley. Such an important question. I think burnout underscores so many challenges that we're having in the system, and I think our understanding of the impact of burnout has really evolved over the last 10 or 15 years. We know that levels of burnout in physicians have doubled, as I stated, and we know that burnout is mostly related to working in systems that are not functional, and that is the root cause of burnout for physicians and other healthcare professionals. We also know that burnout directly links to things like productivity as well as quality of care and medical error. So addressing burnout and creating a system where healthcare workers can thrive and be healthy is critical to delivering quality care to Canadians.
Thank you, Dr. Smart. Ms. Silas, I'd like to ask you the same question, and keeping in mind scope and optimizing scope of care of nurses with such a broad profession as nursing is.
Mm-hmm. So the numbers are very similar to what Dr. Smart said. We're talking about 50% increase, but there's a difference. There's a difference between feeling burned out that I just want to hide underneath my desk or in a corner, than the over 30% that need clinical help, clinical mental health. And that's where we're seeing a big lack because there's a lack of services everywhere. And that's not only impacting on the productivity, because I do think when we survey nurses, they do say that the care they're trying to give is good, but there's not enough of them. But what it does say is they want to get out. And that's, again, why we need to look at retention. Out west from Manitoba up, we have registered psychiatric nurses, again, in a different role in the prairies on what to do with mental health. So we need to be innovative everywhere across Canada, how we're going to deal with mental health, both from those giving the services in healthcare and those other Canadians that need it.
Thank you. I'll move to Dr. Sulez. Bonjour, merci pour la présentation.
Hello, and thank you for your presentation.
We know that technology is one of the largest drivers of healthcare costs. So how do you see the balance between evolving technology, adopting the technology, and yet managing the cost driver of that newer technology presents?
Yeah, thank you for this question. Actually, it's a very good question. Definitely, when you look at the imaging, it's true that the capital investment is quite significant, but the cost of not having a timely diagnosis is really expensive. So we need to take in consideration that balance of the money we put in, the investment, and the cost efficiency of the benefit we will have on that, on the patient workflow and patient care. And in that regard, it's clear that there is more and more investment now in information technologies, on new technology that will facilitate that workflow, and that will really put us in a position to treat more patients more efficiently in a shorter duration of time. So if we target our investment, we can really have a good return on investment. Another example is the clinical decision support system. This kind of information system, the first line or the first line physician can really do the imaging requisition, but he is guided when he do that to be sure that the requisition is appropriate or relevant for the patient. Mm-hmm. Having this kind of system installed across Canada, we can save 10 or 15% of unnecessary examination. So the investment on the return on investment can be very good. And we need to really focus on that balance.
Thank you. Thank you very much. My also former colleague, Paul-Émile Cloutier, I'd like to maybe ask you, when you talked about resiliency of the healthcare workforce, the cadre, do we have the right mix? Do we have the right mix of healthcare professionals? And if not, what's missing? What's too much? You're muted.
I don't think that we have the right mix, and I'm not sure I have the answers to what right mix should be. But I think the message that we're trying to give today to the committee is that we need to review this very carefully, taking consideration of all of the professionals that work in the health system. I mean, you were mentioning just a few seconds ago how many people have actually left because of their burnout, the whole bit. We did a survey with the Ontario Hospital Association in Ontario, and I have the numbers that in terms of all hospital staff from 20 to 21, 45% of people have actually resigned. Of the nurses and RN specialty, we're looking at 71% of the nurses have resigned from 20 to 21. And then service, which is the service that provides the service to physicians and nurses, about 40% have resigned from 20 to 21. So clearly, there's a message inside the system that it's not working, and a lot of people are leaving because they are burnt out. They see that the system is not changing and it's not getting any better. And my fear with this exercise that we're looking at is that if we don't look at the system as a whole first, before starting to say, let's do this for the nurses, let's do this for the radiologists, let's do this. And I know that there's a need across the board. I'm not being critical here. Okay. But if you address only the physicians and the nurses and you don't fix the system as a whole, you will not have done any good service to Canadians and to patient care. That's my view.
Thank you, Mr. Cloutier. Suite, c'est le tour du Bloc québécois.
The Bloc québécois, Mr. Thériault, 6 minutes. The floor is yours, please. Thank you very much, Mr. Chairperson, and I'd like to thank all of the witnesses for their contributions to our understanding today and in the search for solutions. I'd like to direct most of my questions to Mr. Soulez and Mr. Cloutier. The last time that we met, Dr. Soulez, we were in the midst of the third wave of the pandemic, and we talked at the time about structural issues. Now, it's my understanding when it comes to labour retention today and working conditions, these issues preceded the pandemic and have been exacerbated by the pandemic. Therefore, they are structural. So when faced with structural problems, doesn't that implicitly mean that we need structural solutions to those structural problems? And associated with that is chronic underfunding. In the first wave, we were told that chronic underinvestment left us in a fragile situation. And now it's akin to an apocalypse. There's a time bomb when it comes to healthcare networks, which will have ripple effects over the next 10 years. Shouldn't we, in view of that, start talking about structural funding? I'll let you answer that question, then I'll turn to Mr. Cloutier. Response. Well, I think that your remark is highly relevant. What we're seeing currently is that provinces' operational budgets are scarcely allowing them to address immediate needs and to provide services. The provinces are doing it very tough when it comes to infrastructure and a restructuring of the healthcare system. Quite clearly, they need additional funding for long-term overhauls and reforms. We're talking about structural investments. I think that there needs to be a cooperative process with the provinces so that we can define what the needs are. They're clearly not the same across the board, across Canada. We need a flexible, integrated strategy that allows all the jurisdictions to invest in the top priority areas. But the federal government needs to assist structurally with long-term investment. And as I said earlier, there needs to be a return on investment, but they shouldn't just be paying, quote unquote, the grocery bill as a sort of a band-aid approach. Question. Well, healthcare transfers are indexed at 3%, and Health Canada, in its brief in 2021 before the Standing Committee on Finance, indicated that in the short term, we'd have system costs to the tune of 8.4%, and that through 2027, there was only 3% indexation. And, we're not talking about large increases in transfer payments. Quite obviously, the government isn't taking it seriously if they don't invest massively in the top priorities, which is healthcare currently. Mr. Cloutier, don't you think that first and foremost, if we want to be able to retain a labour force, we need long-term, recurring, structural funding in significant amounts. You're on mute, sir. Well, that's an excellent question. And I agree what Dr. Soulez said a couple of moments ago. Quite clearly, there is a grave lack of funding in Canada when it comes to adequately funding the healthcare system. I'm not going to hide that fact. There are huge needs. My greatest fear, Mr. Thériault, is that if there is funding, without knowing why that funding is there, without having a rationale for that funding, without addressing specific needs in the system, we might see what has occurred in the past, i.e. that we fund the system without the outcomes we're looking for. And I think that the Prime Minister and all the provincial premiers, in fact, I wrote to all the premiers at the Conference of the Confederation and explained to them that we agreed that the federal government has to play a leadership role in funding the healthcare system, at least more than what they're doing currently. That much was clear. But that funding has to be strategic and needs to address the priorities in each of every province and territories. Let me give you an example. There are $4.5 billion for mental health, let's say, that's on the table. Mental health is a very, very broad category. Some provinces have certain priorities in certain axes of mental health, whereas other provinces have different ones. And that is why we need politicians to be a tad more flexible in this regard, knowing that at the end of the day, the federal government will target its funding to priority areas, but with certain accountability when it comes to outcomes. And I think that that's what Canadians really want to see today. But to respond to your question, there is a significant dearth of funding from the federal government being channeled to the provinces. I looked at the Canada Medical Association's Deloitte report, which testified to the fact that there was $3.5 billion gap in terms of funding. The provinces and territories are missing $3.5 billion, and I don't think that the provinces will be able to get that money themselves. You've run out of time, I'm afraid, Mr. Thériault. You've run out of time. Thank you very much.
Mr. Davies, please, for 6 minutes.
Well, thank you, Mr. Chair, and thank you to all the witnesses for being here and lending us your expertise and great ideas. Ms. Silas, if I could start with you. I'm just wondering how reorganizing the way that we deliver care may impact on the burnout and the way that we can actually retain the staff we have. And I'm thinking of things like team-based care or maybe expanded scope of practice. And I'm just wondering if you see any opportunities for reorganizing the way we actually deliver the services that might actually get us more efficient in terms of how services are delivered to patients.
Well, Mr. Davies, you've been on this committee for a long time, and you know that all of us have been promoting, delivering care in a different way. We started back in the 1990s with more community health centers to provide better primary care, and we're still in 2022 asking for better primary care. The team, if I look at team nursing, it all depends who's going to be on it and what it's for. We have years and years of science talking about the right nurse for the right patient. So the right skills, the right education, experience for the patient. And it all depends. The sicker you are, the more skills you need and the more education, et cetera, that you need. We have to be very careful of what some employers have done during COVID, building these new models of care that are plainly just dangerous. So we will work on that, but totally agree. We need to go more towards home care, community health center, increasing it in mental health. Similar program to what the federal government established about 1.5 years, 2 years ago, the Wellness Together program, which is an online mental health resource. You know, it's there, it's available for everyone. Okay, now what do we do next?
Thank you. And I think you just very diplomatically called me old. So that's
just as old as me, because I've been around as long as Paul-Émile Cloutier.
As long as me. Dr. Smart, if I can turn to you, you know, I remember as long ago as 2007, Jack Layton, the former leader of our party, was crusading for more family doctors. And I think the figure at that time was 5 million Canadians didn't have access to a family doc. So I'm going to fire 3 quick questions at you, and you can answer all of them. One of them is, you talked about burnout, and I'm just wondering if there's any appetite from your members to move from a fee-for-service type of pay structure to more salaried positions as part of the solution to maybe helping docs who feel that pressure of seeing a lot of patients. Is that something that's worth exploring?
Thank you for that question. I think it's a great question. And again, I think it relates back to this issue of what are some of the structural issues that are impacting healthcare delivery. And I think there's no question that some of the existent payment and structural models for primary care are preventing people from choosing longitudinal family practice. We have many examples of successful team-based primary care in Canada that could be scaled. We have experts who are primary care providers themselves who have done research in this area, suggesting that different models of payment and working together in a team can better serve Canadians with better health outcomes. So we definitely think these are things that need to be explored and linked to this $3.2 billion investment in primary care. And part of the need for the integrated health workforce planning is understanding what are the barriers to our new family doctors choosing to provide longitudinal family practice opportunities for patients.
Thanks. I just want to give you a chance to expand a little bit more on what I think is a very creative and novel solution, which is this idea of national licensure for practitioners. And I'm just wondering, can you give us the 30-second elevator pitch on why that's something that the federal government or governments across country should do?
There's many reasons why national licensure, I think, can be a huge benefit to Canadians, but I think primarily it relates to access to care. As we're learning more about virtual care and how it can be deployed, a pan-Canadian license suddenly allows any practitioner in the country to be available to any patient. It also provides opportunities for health workforce mobility to provide supports in rural and remote parts of the country. So I think there's many, many benefits for physicians and for patients that will improve access, sustainability, and retention.
Thank you, Mr. Cloutier. There's a number of questions I want to ask you. I don't think I'll have time, but one of them is on what the federal role is. I presume that workforce shortages occur across all provinces and territories and across all professions, as you've pointed out. So I'm curious, and you've also mentioned the importance of data. I'm going to lead you a little bit. Do you see the federal government playing a convening, coordinating role for helping all of the provinces who are clearly suffering from the same issues to gather data and help plan a national vision to deal with this problem? And if so, I guess I want you to tell us what you see as the federal role in helping address this issue.
Well, certainly that's an excellent question to be asked. And believe me that data across the country is not uniformed at all. There's no standard plan as to what you're getting, and you're getting it for what. So I think the federal government's role would actually to be a convener, a facilitator in getting that kind of data, and work with the provinces, and as well work with the regulators and working with the major national health associations who collect certain data. But at the end of the day, what you want is a system that is standardized across the country so that you know exactly where there's a gap in either nursing or physicians or in technicians. And you know, when we talk about burnout, and I need to say this, and I know this has nothing to do with your question, Mr. Davies, but I was speaking with some of our CEO members. there's a big scare at this moment that following COVID, that many of our managers who are leaders within the hospital, the research hospitals, will all say, hasta la vistas, I want to go home because I've had enough of this.
Thank you, Mr. Cloutier. Do you just want to finish your thought there? We're well past time. Just go ahead.
Yeah, my closing point is that this stress is not just at the clinical level, it's across the system, right from the front line right up to the leader of any institutions. But to answer your question, the government should be a facilitator and bring all of this information together.
Thank you, Mr. Cloutier. Mr. Davies. Next, Ms. Nyman-Cramp for 5 minutes, please.
Hi there, I'm Shelby Cramp-Nyman, Hastings, Lennox, and Addington. I'd like to start by certainly thanking all of you for joining. I'm not a doctor by any means, so I am pleased to be surrounded by all your level of expertise. This is my first term in office and my first time on the Health Committee, and I'm thrilled to be here. So I'm going to start by jumping into something that has already been spoken about somewhat, and that is the issue of burnout, workload, stressors, anxiety. Years ago, becoming a nurse is something that was a very sought out career. And I think that's it should still be the case. But until you are a nurse during a pandemic, then it's the last place you want to be. So we should work to try and regain that for encouraging people to get into the workforce. So I'll speak a little bit more specifically. So excessive workloads due to insufficient human resources in the health workforce, they were happening before COVID, and if anything, they've been highlighted by COVID. And the additional stresses and the anxiety that has been brought on by the pandemic, it's resulted in additional burnout. Mental health is huge, and consequences that we're all seeing in our colleagues and our neighbors and our friends, and especially in the health field, is anxiety and depression. So you've already spoken to some of the levels. There's 50% burnout, 45% are wanting to resign. So this has already been spoken about. But do you see any specific supports that the federal government can play in this regard, with regards to the federal government being able to provide healthcare professionals and providers within their respective organization? So how do you see the federal government, and what role do you see us in providing that level of resolve with regards to mental illness and stressors and anxiety? Big question.
Not sure who you're addressing your question, but you said nurse, so I'll jump in. Welcome to this committee. You'll see it's the best committee on the Hill, very productive. The federal government did it before, and that's what we have to remind ourselves. The last crisis in health human resource was in 1997. There were roundtables established by the federal government from 1997 to about 2008-ish. Then we hit a recession and everything went down the drain then. But we had nursing sector studies, medical sector studies, allied health sector studies. We are way too small of a country to expect 13 jurisdictions to have all the data, all the best practice, all the experts. That's where the federal government can come in, and they can fund these projects. And I think Paul-Émile Cloutier said it well, that we have to have accountability. Yes, the federal government needs to increase from 22 to 35, but there has to be a plan from long-term care, mental health to acute care.
Okay, perfect. Thank you. Thank you very much for that. My second question is complete curveball. So in regard to, we were talking about mental health and burnout, I'm going to talk about recruiting new doctors and nurses. So the federal and Quebec governments, they have jurisdiction over immigration. And an option for recruiting healthcare providers is to accept internationally trained people. I think this pandemic has highlighted the need for this. So can any of you speak to what initiatives have been implemented to encourage individuals from other countries to become part of Canada's workforce, or individuals that have studied elsewhere, not in Canada, to get on the roster here in Canada? And of those, which professions have been the focus for these initiatives? And in your view, have these initiatives been successful?
I can comment on that. Thank you for the question. We know there are huge barriers right now for international medical graduates to be able to practice in Canada, and there are many physicians that were trained in other countries who are living here who are not working in the healthcare system. And there's many barriers to that could be addressed with initiatives from the federal government. Some of the issues are ability to have people trained and assessed within our system, and the cost and the barriers to doing that. So that's an area that could be supported by the federal government. The other piece is how the assessment and licensing process, and much like referring back to the need for pan-Canadian physician licensure, we also have that same process where each province and territory has its same way of assessing credentials and training and licensing international medical graduates. So that creates a huge bureaucratic barrier. So we feel there's certainly opportunities for the federal government to support international medical graduates to be able to better access the system, access the training and the supervision and the assessment that they need to enter our system. And there's also the side to make sure that the licensure process is more transparent and clear and that there aren't barriers there. We're also aware, the other thing I would say is that there are, of course, ethical concerns with Canada not creating enough of its human health resources within our own country and taking those resources from other countries. So we do believe in the long term, we need to be self-sufficient in creating enough of the resources here. However, there are many physicians, nurses, and other healthcare professionals who are already here in Canada that currently are not able to practice.
Thank you, Dr. Smart, and thank you, Ms. Knapp-Nyman, and please accept my apologies for misstating your name at the outset. I'll endeavor to ensure that.
I very kindly, diplomatically
corrected
you.
Yes, yes, and I appreciate that. Mr. Joe Harry, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to our witnesses. But before I get into my question, I just wanted to, on behalf of myself, my colleagues in this committee, as well as all the 338 members and all Canadian, please extend our gratitude to all your members. We thank you. We thank your members for what you have done over the last 2 years, and you continue doing despite all the uncertainty, all the unknown, for keeping us safe. So thank you. It looks like, as I was listening to the testimony, once again, thank you for your testimonies. Virtual care is emerging as one of the ways that we may be able to address the gap. I talked about the gap, but I want to start our first question from my first question from Mr. Burrow. Mr. Burrow, you talked about OECD, and you talked about what I perceive the gap between the funding and between the delivery. It looked like we are number 6th or 7th when it came to the amount of investment that we do on healthcare. That's put us on the top 20%, and yet we are ranking 25, 26 out of 38 when it comes to delivery or capacity. How do you explain that gap? And if we want to close that gap based on the current funding, where would we be, and how we could benchmark against those who are at the 6th and 7th, but also their delivery at the top 20%?
Thank you so much for your question. You're absolutely correct. There is a fundamental imbalance between how much Canada spends on healthcare and what it gets in return. As you mentioned, we rank 6th highest in the OECD in terms of healthcare spending per GDP. If we start to adjust that for age, we actually end up ranking 2nd highest. And the reason why I'm stressing this point is because when the conversation starts to revolve around more money being pumped into the system, we have to understand that we're already one of the highest spenders. We have a federal government that is deeply in debt. We have provincial governments that are not going to be balancing their budgets for a while in many cases. We have to really understand why this money isn't translating elsewhere. And it's not just in terms of resources. We also have some of the longest wait times. We have the longest wait times in the developed world. We rank mediocre when it comes to utilization, and we have a mixed record when it comes to quality.
My apology. How do we address the gap
between the two? The simple answer about
I apologize for interrupting you, but how do we address the gap? So you've told us we got the money, but you've told us from a capacity point and delivery point of view, we are not there. And Mr. Coutier talked about a structural investment and a long-term investment and flexible and collaborative. How can we address that gap?
I'll reiterate the 3 points that I made in terms of differences of policy. That's what qualifies a more successful healthcare system from a less successful healthcare system. There are 3 things that these other successful healthcare systems do. They partner with the private sector in order to either as a partner or as a pressure valve. These are countries like Australia, Switzerland, the Netherlands, Germany. Importantly, they also temper demand. They expect patients to share in the cost of treatment, which is a vital strategy in many other countries, in almost every other university healthcare country. And importantly, they fund their hospitals based on activity, which is very different than how Canada does this. This way of funding hospitals incentivizes hospitals to treat patients and ensures that hospitals get paid whenever a patient comes in. That takes away the entire process of having the sort of budgeting that we have. The last thing I'll just mention in terms of virtual care, because you mentioned that, and I do want to talk to that point, and that's that I think virtual care will absolutely help in many cases and has already been taken up. However, it's important to understand that virtual care so far is only really in the realm of GPs and physician services.
Yeah, thank you. Thank you for going to. Thank you for going to virtual care. In your closing, in the tail end of your opening remark, you talked about challenges facing virtual care vis-a-vis the Canadian Health Act. Can you briefly make some comment on it? And if you run out of time, can we make sure that we have a submission? Because this is really important for us to understand what those challenges are. Thank you.
Thank you for the question. This is really an unexplored area, and I think will not be a challenge for a while, but it's very important. Virtual healthcare is usually offered by services that are really outside the public healthcare system, and these services are offered also for pay. As you well know, when you have user fees and charges, that creates conflicts with the Canada Health Act, the way it's structured in terms of sections 18 through 21, in terms of user fees and co-payments. Once these services, which are considered like virtual services, if they are considered medically necessary, this may create a conflict in the future with the CHA. This is not explored right now, and I hope that it doesn't get to that, but it is a potential problem in the future. But again, I stress that virtual care right now is only a solution in the area of GPs. It's not going to help with specialists. It's not going to help with over.
Thank you, Mr. Barua. Mr. Thériault pour...
Mr. Thériault, 2.5 minutes. The floor is yours. 2.5 minutes, not much time. Dr. Cloutier, you said Canadian healthcare transfers haven't kept pace with the increasing costs of healthcare caused by inflation, demographic growth, an ageing population, the state of health of the public, improvements to the healthcare system that are necessary, and we should add to that, at the tail end, the pandemic. And yet, you said earlier that you think that Quebec and the provinces that are bending over backwards when healthcare is concerned are not perhaps using the healthcare transfers optimally on the ground. So the federal government for the past 30 years has never done its fair share, such that we wouldn't be having this conversation today had they done so. This is an unusual situation, isn't it? Wouldn't it be better that they stood in unity with Quebec and the provinces to provide substantial, recurring transfer payments so that the provinces can repair what is still repairable in their healthcare systems? You're on mute. I'm sorry, sir. The chair will give that time back to me, I'm sure. Excellent. Well, perhaps my response was misinterpreted. You were probably looking at our pre-budgetary brief, And in that brief, we agreed that the federal government should, when the time comes, increase healthcare transfers to the provinces. That goes without saying. Everyone agrees with that. Question, well, don't you think that it is now high time for that to occur? If we're short of doing that, the costs over the weeks and months are continuing to go through the roof because of the pandemic. And there are people that aren't even getting screened for cancer, and that will cost more money down the track. Response, well, that's where there needs to be a collaborative approach between the federal government and the provinces. At Healthcare Can, we've always consistently called on the Prime Minister and the Premiers to hold a conference on healthcare to address or to assess the state of affairs in healthcare costs in the provinces, because the costs in one province aren't the same in another. Would you agree on a summit on the cost of healthcare? Yes, I would agree entirely with the summit being held. Thank you very much, Mr. Cloutier and Mr. Thériault.
Davies, please, for 2.5 minutes.
Thank you. I'm not sure which of Ms. Silas, Dr. Smarter, or Mr. Cloutier can answer this, but my two questions are this. What steps can or should the federal government take to improve credential recognition for internationally trained healthcare workers? I think this is a perennial issue in this country. And second, I suspect our immigration system is at least part of the solution here as we identify shortages. How can we more effectively use our immigration system to plug some of these holes? Any one of the three of you who cares to has an opinion on it?
Mr. Davies, I'd like to ask Elaine Watson to respond to this one, if you don't mind.
Of course.
Of course. Good afternoon, everyone. Happy to provide some thoughts. So I think there are some elements of the application system for internationally trained healthcare workers. It is difficult to navigate. There can be some aspects of the labour market impact assessment that create a barrier. We could work more effectively with the licensing bodies and their counterparts in the countries that people are immigrating from. And I think we can also make it easier for people once they arrive in Canada. As an immigrant myself, I can tell you that the application process and getting into the country did not match my experience when I got here. So helping people to settle in the country, to be able to access those roles as quickly and effectively as possible, and making sure that those licensing requirements are all dealt with before people actually get into the country are ways that the federal government can help. And I think there's some quite straightforward elements to that that can be addressed quite quickly.
Ms. Silas, what about nurses?
Agreed with Ms. Watson. We do have a over-regulated system in Canada by province, by territories. Dr. Smart talked about it. And it is very difficult for all province and territories to go recruit outside our country because there's literally no support. But again, I'll reinforce, just like Dr. Smart mentioned, we need to grow our own. We are a large country. Nursing, medicine, radiology, etc. are all beautiful professions, and we need to make it great. But key, as Ms. Watson said, is yes, those internationally educated healthcare professionals that do come to our country, we need to facilitate it, and we need it to make it welcoming when they establish their roots in our country, especially in rural and remote. It is very difficult to go live in rural and remote when you've never lived in Canada at all. So the federal government can play a role to help all the provinces and territories. And it goes back to our main recommendation. We need to bring all the experts together to what are the best strategies, the best practice across the world that we can steal from, that we can borrow and implement in our country.
Thank you, Ms. Silas. Thank you, Mr. Davies. Next, Mr. Lake, please, for 5 minutes.
Well, thank you, Mr. Chair, and thank you to all of the witnesses, just echoing my colleagues' thanks. Mr. Barua, I'm going to come back to you. I'm going to make an admission. When I first voted, 1988, I voted for the NDP. So full disclosure here. And the reason I switched politically over the years, I speak to university students a lot, and they ask me this question. And it's not because the things I care about changed. It's because I think how we get there changed. And a big trigger for that for me were the cuts in the 90s to the transfers, particularly the health transfer, and I believe $35 billion over multiple years was cut. I actually pulled up a chart here, and it's more shocking when I'm looking at the chart than I even remember to see those devastating cuts. And of course, it was a Liberal government at the time, largely instigated by debt that was run up in the 70s and interest charges in the 80s on that debt. And so, Mr. Barua, I just want to ask, first question, what was the impact of those cuts in the 90s, and have we ever really fully recovered from those?
Thank you for the question, Minister Lake. I'm not entirely sure I can answer the question directly. What I can say are two things that may be relevant. First is that the situation with physicians is directly traceable back to the Beres-Stoddard report of 1991, which recommended a 10% reduction in medical school enrollment and 10% reduction in residencies, and also less reliance on foreign physicians. This was reversed somewhat at the end of the 1990s, as Dr. Silas mentioned, with the Canadian Medical Task Force when enrollment started up again. But, and this is the important caveat, enrollment and residencies and all this only makes so much of a difference if there are no jobs. And the jobs that we have in Canada that are offered are restricted heavily by global budgets. To that point, in 2013, there was a survey by the Royal College of Physicians, which showed that I believe 16% of newly graduated physicians could not get a job in Canada. So these are things that are tied together. And the reason why I bring it up is to caution simply looking at increases in the medical workforce without looking at how those jobs and how those services are going to be funded. The second thing that I just want to highlight, when it comes to things like the Canada Health Transfer and the federal government's role, it's important to start from the point that healthcare is technically actually a provincial responsibility. It is the federal government uses essentially spending power in order to dictate the characteristics of the province's healthcare systems through the Canada Health Act. And so we have to. Why it's important is because what works in British Columbia might not work so well in Prince Edward Island. And one of the things that happens when you increase, for example, the Canada Health Transfer in excess of GDP growth rate, which is what is currently being done in accordance with both Prime Minister Trudeau and Prime Minister Harper's governments, is that you actually have a further reliance of the provinces on the federal government, which means less ability to actually tailor their own programs. So I know I didn't answer your question directly, but those are just two, I think, important pieces.
To that end, I think everybody in this committee agrees that we need to increase investment. I know our platform had a $60 billion investment over 10 years, including significant focus on mental health. But when I take a look at your opening remarks, you talk about us being very high in spending and very low in terms of some of the other numbers, sort of the outcomes of that spending. If that's the case, what are we spending the money on?
That's the entire healthcare spending question. I cannot answer that question directly, but what I can say is that the policies that differentiate Canada from more successful universal healthcare systems are clear and stark. It is the attitude towards the private sector versus thinking about universal healthcare as a government-only approach. It is thinking about the importance of co-payments for tempering demand, which is something that's practiced in pretty much every other universal healthcare country, even if it's purely within the public sector, and is how these hospitals are funded. Those factors are what dictate more what we see in the more successful universal healthcare countries. Just to give you an example, when Canada has, according to the Commonwealth Fund, 62% of Canadians reported waiting less than 4 months for treatment. In Germany, that number was 99%. Okay. In Australia, that number was 72%, Netherlands 87%, Switzerland 94%. What puts these countries together? They all do universal healthcare differently. So I appreciate the discussion that we're having right now, and they will make an impact at the margin, but you're not going to see significant change unless you actually think about significant reform at some point.
Thank you, Mr. Barua. Mr. Lake. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses. This is a great testimony. We all know that there's a workload on the healthcare workers and burnout, mental health is impacted. And then now shortage of healthcare workers, we are discussing that. And when we met last month, Ms. Salas and Dr. Smart, you can also answer that. An issue that we all hearing about even before the pandemic was the issue of trained healthcare workers not being able to work in their field. They come here as a skilled worker, but are limited by provincial regulatory bodies. Then the pandemic began, and some provinces gave them emergency authorization. Now that there is no agreement, we don't disagree that we need more healthcare workers. What are your organization going to be help and barriers that skilled workers face? And do you think is the lack of training resources? Can you, Ms. Salas, you can answer first, and then Ms. Smart.
Thank you, Ms. Sidhu. The question of internationally educated healthcare professional, yes, it's a college issue, and it's a provincial and territorial issues. You might remember about 7-8 years ago, Canada went to an American-based NCLEX exam to pass for RNs. That when we approached the premiers of each province and territory saying, you made a mistake. One, it's going to attract nurses to go to the US, make it a lot easier. And two, too many are failings, and especially in the French language. All ministers of health said it's out of our hands because we gave them total accountability and responsibility on that. So we have to go back to the health ministers and the regulatory college to fix how they enter and evaluate internationally educated for nurses or others. And that's where the key and where the federal governments can do is, again, bring the best practice to the province and territories. It is crucial to do it. You'll see in our presentation and what we will present, we'll send you a brief, but also what we'll present to the FINA committee is we need bridging programs. And we're working on bridging programs in the early 2000s. A lot of you went back to 1990s. I started it. But 2004, we had a health accord that all the premiers and prime ministers agreed on. Paul-Émile will remember it was signed at 1:30 a.m. in September 2004, where we looked at where the money was going to go and how the money was going to increase 6% per year. So we can do it. We need bridging programs for personal care workers that want to go as licensed practical nurses who want to go at the RN and so and so. And that's how we build skills for our current workforce and our future workforce.
Thank you. Dr. Smart, I heard from my constituents about Canadians who attend medical school here but have difficulty finding residencies. Sometimes they have to go to US to find a position in residency. And I heard you said that there's a barriers from bureaucrat credential or bureaucrat barriers. Can you explain how can federal government can play a role in that?
Thank you for the question. I think there's sort of two aspects to what you're asking. One is the training opportunities for Canadian trained medical students to enter the residency training process that's required to become a practicing physician in Canada. And again, this is part of the issue with not having a national integrated workforce plan is there isn't necessarily coordination of the number of spots available in medical school relative to the number of post-medical school training opportunities. So that mismatch does create some people who have trained to be physicians, but then aren't able to access that next step of training to allow them to actually practice. So that again needs to be part of a plan, and we believe a national lens on that would be helpful. The other piece I think you're talking about is the regulatory barrier and structural barriers for international medical trainees who are physicians from other countries who are entering Canada and unable to work. And again, there's really two issues there. One are the cost involved with accessing a Canadian license, the training and apprenticeship process that foreign trained physicians often need to access to be qualified here, and that is very challenging. It's very cost prohibitive, and there's a lot of barriers in terms of allowing people to access that system. And then there is, again, the fact that because this is regulated by the provinces and territories, the approach to credentialing and what's required to obtain the license is different in every province and territory. So again, there's no kind of singular structure, and that creates a lot of unnecessary challenges and barriers at that regulatory level. So I think the opportunity for the federal government would be to provide that support, whether it's through bursaries or other monetary supports, to allow foreign trained physicians that training and the financial support needed to be able to access it. It's upscaling the availability of those opportunities, and it's creating a pan-Canadian approach to credentialing and what those requirements are for Canadian licensure, so that we're not having these individual provinces and territories creating regulatory barriers for foreign trained providers.
Thank you, Dr. Smart. And Ms. Sidhu, next we're going to go to Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair, and again, thank you to the witnesses. A quick answer to this, Dr. Smart, I'm wondering, the advocation for a pan-Canadian license, are you suggesting we get rid of provincial colleges and registrars?
Thank you for the question. No, I don't think that we're suggesting that, but I think what we would like to see is better coordination. So one national standard that every Canadian physician can be umbrellaed under, with ongoing cooperation and coordination at that provincial and territorial level, which will still be important from a regulatory perspective. But we do believe that there's opportunities to have that pan-Canadian license with coordination of existing structures, but being able to break down some of those barriers so that you aren't necessarily having to seek licensure in each individual province independently.
Yeah. Unfortunately, as a physician, it sounds like another layer of bureaucracy to me, but that's just me. Dr. Soulez, if I could, we talked a lot here about virtual care and the perhaps utility thereof. Do you see any difficulties, sir, as it relates to your profession as a radiologist, the more virtual care perhaps that primary care physicians or teams are using?
Yeah, that's a very good question, actually. It's clear that the virtual care definitely increase the load of imaging, because the physician do not examine their patient. And so we have seen more ultrasound, more CTs, and this is something we need to take in consideration when doing virtual care. And this increasing imaging demand, we cannot address that. We are behind schedule. So more than ever, it's very important to improve the guidelines and the referral guidelines, being sure that every examination is relevant.
Thank you, sir. Appreciate that. Mr. Cloutier, I'm wondering, you talked in your original statement a bit about immigration, and I wonder if we're noting any specific holdups of the federal government level. Certainly, as members of Parliament, we understand the deluge of cases of immigration holdups, and I wonder if you have any comments specifically how that relates to healthcare professionals wanting to come to Canada.
Sorry, it's an excellent question, and if you don't mind, I'll pass it on to my colleague, to Elaine Watson, to respond to this one.
Thank you.
Yeah, thank you for that. And I think I would give a similar answer to the previous one. I think that it's if there was an ability to expedite healthcare workers that have been identified to have the skills and the knowledge and the experience to fill the positions that we have available in Canada, that we expedite their entry into the country, that we minimize the bureaucracy related to their licensure, that we can start that process before.
If I just might interrupt you there, and I apologize for that, but I'm wondering, I know that there obviously, there's strategies. Do you know that specifically we are encountering delays with respect to immigration as it pertains to healthcare providers?
Yes,
do you have any data on that? We are. And do we know how long the delays are?
I can't tell you, I can't answer that question right here. I can tell you that they are significant. It's obviously slowed down during COVID because of the barriers that vaccines and entry into the country have created. So I would say it's not necessarily an issue right now, but it is something that we're going to have to pay attention to with the deluge of exits and retirements, etc., that we're going to see once pandemic is dealt with.
Right. Thank you for that. And Ms. Silas, I'm wondering about us accrediting programs abroad. I understand currently that the National Nursing Assessment Service is a accreditation service that's actually outsourced to the United States. And I wonder, A, is that true? And B, what's the likelihood of us sending accreditation teams to, say, nursing programs abroad?
Yes, it is true. And some provinces are sending accreditation team outside abroad for nursing programs, mostly in the Philippines, and that exists. And some provinces believe that that's the way they're going to fix the shortage. I can tell you now, it will not. And we need to work on a better and broader pan-Canadian health human resource strategy to do it.
Thank you. And Mr. Barawa, I don't think we have too much time. I wonder about do you have any ideas, sir, about the cost barriers to educating healthcare providers in Canada?
Fortunately, that's not something I've looked at recently.
And perhaps Dr. Smart, do you have any comments on that?
A brief answer, if you could, please, Dr. Smart.
I think one of the things we know is there's huge costs to obtaining training in medicine, and that can be a real barrier when you look at diversity of who enters medical profession right now, and that then, of course, goes on to where people choose to ultimately practice. So I do think that those cost barriers do have an impact.
Thank you. Dr. Pawlowski, please, for 5 minutes.
I want to first of all start off by commenting that Mr. Lake said he started voting NDP, and as he got older and presumably a little wiser, he joined the PCs. I think maybe a couple more years and a little more wisdom, eventually he'll become a Liberal. Well, following on from that, Mr. Barawa, you talked about underfunding of the system. It seems pretty clear that you think that that's a large part of the problem. And what are we going to do about it? That is the question. And how accepting are Canadians going to be of higher taxes in order to pay for higher health care? I know Luc talks repeatedly about the need for more money going to Quebec in order to provide adequate health care in Quebec. I think other provinces feel the same way. But again, how much are Canadians willing to pay? Now, Mr. Barawa, you've talked about user fees and the option of private healthcare, which both seem to be prohibited under the Canadian Health Act. And should we allow those things? Most Canadians, and I think there's been a number of surveys when people have asked Canadians, what's the most important thing for you in defining what a Canadian is, or what's the most important value as a Canadian? And people repeatedly say two things: hockey and universal healthcare. And clearly of those, the more important one is hockey, but healthcare comes a pretty close second there. And so would Canadians be willing to countenance user fees and privatization of healthcare? We're all politicians here, and basically, would this sell in Canada, Mr. Barawa? Maybe I could start off with you. Do you think Canadians would be willing to accept that? Is any party going to have the cojones to do that? And is this something maybe we need a national referendum on?
Thank you so much for the question. That's quite a big one. Let me start by saying I just want to clarify. I don't think I explicitly said that underfunding is an issue. We are one of the highest spenders. I think there's an imbalance between how much we spend and what we get in return. When it comes to the policies that separate us, I do want to reiterate there are actually three. It's not just private healthcare and user fees, but it's also how hospitals are funded through through activity-based funding. What you said in terms of the identification of universal healthcare as a core Canadian value, it's important to stress that universal healthcare is not in any way does not in any way mean only a government-mandated healthcare system the way that Canadians have been led to believe. Most other countries with universal healthcare have really a hybrid system with most of these policies. Switzerland and the Netherlands, for example, are at one extreme of universal healthcare where they simply mandate all of their residents to purchase private healthcare in a market that includes both public and private providers. Most other countries, including Australia and Germany, have both public and private hospitals delivering public services. All of these countries have some level of user fees. Some of them are deductible. Some of them are small co-payment, like 10% of the cost of care. All of them have exemptions. All of them have caps on the total level of out-of-pocket payment. These are all universal healthcare countries, and all of them fund their hospitals in a different way. To your last question regarding political appetite and also the Canadian appetite, I can't answer anything regarding politics. I'm not a politician or a political pundit. What I can say is that there are a lot of new surveys that do indicate that Canadians are changing their view in terms of their how they perceive reform and their willingness to experiment and try with different things that have been shown to work in other countries. This is obviously a result partly of our overburdened public healthcare systems, but also as a result of a better understanding of how other countries with universal healthcare simply do universal healthcare differently.
Maybe can you cite in a little more detail those studies as to the acceptability? Because again, although other countries which provide universal healthcare may allow extra billing and some privatization, I think most countries, when they think of universal healthcare, do not think of those things as being part of it. Do you have further, and maybe you don't, if you don't, that's fine, but do you have further kind of numbers and evidence? Because again, I'm figuring the Canadian public will not buy this. They'll consider this is an unwarranted compromise of the universal healthcare system, which is so important to all Canadians.
A brief response, if possible, Mr. Barua.
Response, I don't have the numbers on hand, but I believe that the last study that we might find useful was conducted by secondstreet.org in Alberta. With regards to Canadians accepting these sorts of reforms, I will say this: I have great faith in Canadians and their ability to understand new information. And I think the pandemic has shone a wonderful light on how other countries do universal healthcare and how many of them do it differently, and how many of them actually have features that are probably valuable in the Canadian system. Of course, all of this would be understood to be within a Canadian framework, which would be unique in its own way.
Okay, thank you. Monsieur Thériault, pour 2 minutes et demie, s'il vous plaît.
2.5 minutes, Mr. Thériault. Thank you very much, Mr. Chairperson. Dr. Soulez, practicing in Quebec, well, you know, in Quebec since 1992, there's been 3 overhauls of the healthcare system in order to be able to do more with less resources. That's been the attempt on 3 occurrences. In your short-term assessment, what do we need? In the mid-term, what do we need? And over the long haul, what do we need? There's been a lack of resources over the past 30 years, so obviously we need to train the new blood. But in the short term, what is the most important action? And then at the end of your response, if you could tell me if you're in favour of a summit on healthcare, that would be great. Well, that's a very broad question. I'll try and focus on MRIs, if I may. Well, overall, in the short term, there are 2 urgent issues that need to be addressed in short order. First, improve working conditions, retention of our medical radiation technologists. That's crucial. We have a shortage of MRTs. We need a retention strategy immediately. The profession has been undervalued and devalued. Second urgent issue, which can't be fixed quickly, but the information systems. Currently, it makes no sense that patients still have to send in faxes in order to get an imaging appointment. So from prescription, requisition, to the appointment. It's not integrated. There's a huge priority when it comes to integrating healthcare systems. That would save us in terms of staffing, and it would mean less pressure on healthcare professionals. Now, what about the long term? Equipment. We need more modern, cutting-edge equipment. But as far as labour is concerned, we need to train them. In Saskatchewan, there's no training programs for technologists. In Quebec, we should train more technologists. Training needs to be improved. We need to value this profession, and we need to focus on retention. If we focus on that, we can ameliorate performance. But I believe a lot in IT. That could help us. And what about the Healthcare Summit, very quickly? The Healthcare Summit, yay or nay? Mr. Chairman, a little indulgence, please.
Mr. Davies, you have the floor.
Thank you. Well, I've made it my mission in life that whenever anybody says that healthcare is provincial jurisdiction, I just must intercede. The Constitution does not even mention the words healthcare and does not give it to either the provinces or the federal government. And in fact, the Supreme Court of Canada has said the following, quote, "Health is not a matter which is subject to specific constitutional assignment, but instead is an amorphous topic which can be addressed by valid federal or provincial legislation, depending on the circumstances of each case and the nature and scope of the health problem in question. The only thing given to the provinces is the establishment and maintenance of hospitals. Of course, 1867, we didn't even have healthcare. Now, the reason I point that out is because I want to drill into something. It sounds to me that as Ms. Silas, as you said, if this is, we've got to develop our homegrown talent here, that means more seats. It means more seats in nursing schools, medical schools, technicians, everything. Would you support, would the witnesses support a federal fund that was targeted to the provinces specifically for the purpose of expanding seats in professions that the province could determine where the scarcity is, but tied funding in that regard? Because I know that some people refuse any kind of tied aid from the federal government. I don't. But I'm just wondering, is that one way to get more seats in these schools to create the bodies that we need?
Totally agree, Mr. Davies. We need support from the federal government, and we need support from committees like yours not to throw in the towel on our universal public healthcare system. There's close to 1 million healthcare workers that have given their hardest and their best over the last 2 years. And the worst thing they could hear right now is we're throwing in the towel and we're going to privatize the whole thing to make a few very rich. So help us educate more, help us improve the working condition, and that will help and reduce all the wait time. We know how to do it. We just need help.
Mr. Cloutier, is that something that we should consider doing, as a targeted federal funding conditional upon provinces using that funding to create more positions?
I totally agree with that position that Ms. Silas pointed out to you, that I think that would be a way to address a component of the problem. My biggest fear is that you have a number of stakeholders here who have all interest with their stakeholders. And I think it would be totally wrong, especially at this juncture, to do something that would only address certain components of the healthcare system, when in fact, I think that post-COVID, what we need to do as citizens and as governments is to start to rethink what kind of healthcare system do we want and need for Canadians post-COVID? Because post-COVID has given us a number of lessons that we weren't prepared, and that we need to prepare for a next virus that might come over to our place. And I think that reflection has to be global. It can't be just, it can't be just about nurses. It can't be just about school. It can't be just about funding. You have to look at the whole system as a whole. And that's why I come back to Mr. Thériault's comment, which is, yes, I think there needs to be a dialogue at the federal and provincial level, including some of the stakeholders around this table, to try to explain what's happening and to try to find a solution that will be acceptable for all Canadians.
Thank you, Mr. Cloutier and Mr. Davies. Next, Mr. Lake, please, for 5 minutes.
That's a good segue, I think, into my line of questioning. Mr. Cloutier, I think that was in our platform. We talked about that in the election campaign, coming together within the first 100 days. I want to come back to, I listened with interest to Mr. Soulez talk about technology and innovation and come back to it time and time again. I talked about sort of the cost of the healthcare system and the fact that all of the parties agree that we need more investment in terms of the transfers. But I want to see how we can get more efficient with the money that we're spending right now. And so my very specific question for each of the witnesses, maybe starting with Mr. Cloutier and Dr. Smart, would be, what innovations in terms of either technology or structure would result in, as it stands right now, and I'm not talking about spending more money, it might be a little bit more money, but what innovations would result in more productivity per hour of work for the folks that you represent?
Dr. Smart, do you want to go first?
Okay.
Sure. Thanks for that question. I think there's several aspects to that are challenging. We're talking about increasing productivity on a backdrop of people that are incredibly burnt out and already working really extensive hours, and in conditions that are very challenging to sustain. You've heard from Ms. Silas about nurses being mandated overtime. It's very common in medicine to work 24 to 36 hours without a break in acute care settings, which is really kind of, I think, shocking this day and age. We have, family physicians providing care throughout the day and then spending hours and hours at home due to the administrative burden now of healthcare delivery after hours and unpaid ways. So I think, when we're talking about efficiencies, I think we need to recognize that right now our system really puts a lot of burden on individual practitioners to overcome a lot of the systems issues that make the delivery of care challenging, and those things need to be addressed. And I think that's why, again, it comes back to what Mr. Cloutier was saying about, or Dr. Cloutier, around integrated planning. We can't solve any of these issues as individual practitioners or at individual levels of government. We really need integrated care plans to look at what are our health human resources, how do we deploy them in a way to meet the needs of Canadians, and how do we allow everyone to be at their full scope of practice so that we do get those efficiencies in the system. But I don't think it's a question that any of us can answer in our own silo. It's something that we really need to come together, look at what the barriers are, what the challenges are, and then come together with actual solutions.
Mr. Cloutier, do you want to weigh in, and then Ms. Silas?
I think what Dr. Smart said, I totally support. When we speak, for me, about integration, it's integration that includes home care, long-term care, because we saw during the COVID that long-term care was like the poor cousin of the system and was just left there on its own. So the integration has to be primary care, acute care, long-term care, and home care. And that thinking's it's starting. I mean, people realize that, the system was wrong in the way it was structured, and that now is the time to have that reflection and have that dialogue as to how you integrate all the components of the healthcare system and making it an excellent healthcare for Canadians.
Totally agree with the previous two speakers, but also Dr. Soulez, who talked about the integration. Over the last 2 years, I haven't seen my primary healthcare provider. Everything's been virtual, either on the phone or a Zoom. But we need to expand that, and we need it to make it safe. And that's an area where we'll all have to be at the same table, from scope of practice, integration, and the virtual world of healthcare. But let's think about it as innovation and not degrading the healthcare services we give to Canadians currently.
But if I may just
go ahead.
Okay. I think we need to, I like the innovation, I like the virtual care, but I think in that equation, we also have to examine what are the risks. And because if we don't examine the risk, we'll never know if in fact what we're putting in terms of innovation is actually going to be helpful and that we're going to have positive outcomes. So that has to be part of the equation.
Thank you, Mr. Lake. And the last round of questions will come from Mr. Van Koeverden, please, for 5 minutes.
Thank you very much, Mr. Chair. I'd like to thank all of the witnesses today for their testimony, their experience, their efforts over the course of this very, very challenging last 2 years. I think this has been a very productive meeting, and I'm really grateful for all of the wonderful testimony. My first question is for Ms. Silas, and it relates to the way that the government has demonstrated a practical approach to partnering with provinces and territories, and I think it's relevant to consider how well our childcare agreements have gone over the course of the last couple of years, and maybe this presents a model for potential future investment and partnership with provinces to provide targeted support in certain areas. And I'd like to hear your reflections on how we might invest and partner with provinces and territories in strategic ways that would improve the quality of care and potentially result in the hiring of more nurses, nurse practitioners, physicians assistants, and doctors. But your reflections on how the federal government can partner with provinces and territories to increase that workforce participation.
I'll mention it earlier about the 2004 Health Accord, where all the premiers and prime minister and health ministers got together and signed an agreement for 10 years. But I also work with many premiers over the years, almost all of them. And if you show them the money, they will make changes. And that's what we're seeing for childcare. It's exactly what kind of money, and then their standards. That's what I expect we will see with long-term care. Show me the money and then the standards. And we need to do it with mental health. We need to do it with our acute care sector. And in our acute sector right now, the crisis is the health human resource crisis. If we don't fix that, we won't have anything to worry about because we won't have a system. So really, you heard from all the stakeholders here, we're calling for an agency of expert with the proper data and the proper funding for strategies to help us to do our job. The worst thing I hear from a nurse almost on a daily basis is I go into work every day and I know I'm not able to provide the care I should be providing. And the sad thing is I know I'm going back in tomorrow to do the exact same thing. And we need to stop that. We need to give them hope. And I have trust in all of you that that's what will happen. You will give them hope with an amazing report from this committee, just like you did in 2019 on violence in healthcare. It was the best report. So now we need to work together and fix it.
Thank you very much. And I wouldn't mind building off of that just a little bit and reference that so many of your membership have been targeted for, in protest and in violent ways that I'm grateful to see that our new law in place to protect healthcare workers from on-site protesting and that violence that has had.
But all due respect, we have to get the police to enforce it. Dr. Smart and I were there when Minister Lametti introduced it, and we were very proud. It was a big success. But look at what has happened in Ottawa and other regions. The police hasn't even read the act yet, so we need to enforce it. It can't just be an act written on beautiful paper. It has to be enforced.
Absolutely.
Sorry to interrupt.
No, it's encouraged. I'm really grateful for that, and I couldn't agree more that a law that's not enforced is certainly not helpful, and we've only seen a few examples of it being enforced in Ontario. I'd like to touch on strings attached. That's a commonly used term now. Really, anybody that feels strongly about this issue, it's probably our last chance to hear from anybody. But I know that challenges are different across the country. We're a federation, and the various jurisdictions experience different challenges. So when considering how to invest and partner up with various jurisdictions, provinces and territories, what types of strings should the federal government consider in those partnerships with provinces and territories?
I could comment on that. Thanks for the question. I think from the CMA's perspective, What we would like to see is that the dollars used by the federal government to motivate action at the provincial level are really targeting what we see as the biggest issues facing the healthcare system. And for us, that's clearly backlogs in catching up on surgery and diagnostic imaging, as we've heard about, commitments to ensure that all Canadians have access to primary care, which is foundational in our system, and also cost savings in the long term when people have a longitudinal care provider. We know that long-term care needs to be seriously addressed, and mental health. So we would like to see strings attached to targeted funding to make sure that those 4 priority areas are actually addressed and that we move the dial in terms of quality and access in those domains.
Thank you, Dr. Smart, and thank you, Mr. Van Couverden. Colleagues, we've reached the appointed hour. So first of all, to our witnesses, thank you so much for being with us. Thanks for sticking it out while we were exercising our democratic duty and delaying the commencement of the meeting. And look, thank you so much for the last 2 years and what you and your members have done and the research that has been presented today. This has been an excellent and informative session. We're extremely grateful to you for your leadership in your respective professions and for the patient and insightful way that you handled the questions today. It will be of great value to us in doing our work and making recommendations to the government. So thank you so much. Colleagues, before we wrap, just a couple of housekeeping items. We'll see each other again on Monday to hear from the public, Monday, February 28th. To hear from the Public Health Agency of Canada and the Auditor General on our COVID study before hearing more witnesses on this particular study on March the 2nd. A reminder that any supplemental witness lists for this study are to be submitted to the clerk by end of day tomorrow, and supplemental lists for the COVID study are due by 5 o'clock on March the 3rd. Is it the will of the committee to adjourn the meeting? We have consensus. Thank you again, everyone, and have a good evening.
Thank you very much.
We're adjourned.
Thank you.